All right, welcome to another protocol update. The new one here is Hydromorphone or Dilaudid. We're going to be making some changes again to protocols and drugs. So let's discuss Hydromorphone in a little bit more detail so that we're all familiar with it when it comes out. Hopefully sometime in August is the current plan. All right, so the education objectives for this PowerPoint presentation today: indications. We're going to discuss the new protocol. We're going to look at the dosage, the route. We're going to discuss a little bit of the pharmacology and historical use, why we're switching from morphine to Dilaudid, and just the normal kind of the protocol review. All right, so here's the indication, the dose, and the route. Obviously, this is an opioid analgesic pain, so we're giving it for pain management. The adult dose, you can see there, 0.5 to 1 milligrams. We're going to repeat that every 15 minutes to a max dose of 2 milligrams. That's going to be IV, IO, or IM for adults. For pediatric patients greater than 6 months old, we're going to be looking at 0.1 milligrams per kilo every 2 hours. We can repeat that once, okay, after that 2-hour period. Pediatric administration is intravenous and intraosseous only because intramuscular injections in this cohort of patients are quite painful, and it's kind of counterintuitive for us to be giving a really painful injection to control pain in a small child. All right, so here's the new ASL protocol. Hydromorphone has been an ASL protocol for a little while, but specifically because we're adding it now to Magic Valley Paramedics, we've tweaked the protocol a little bit. I'm not going to go through it from top to bottom because that's something that will be available to you in the app. Please go in, update your apps, and because if you don't go in and update your apps, the problem is you'll be still looking at the old Hydromorphone protocol. It's okay, but there's not a great deal of changes, but the changes that are there are very important. They specifically relate to the dosage. So have an update of your protocol and go in and have a good read of it when you get a chance. All right, a little bit of a history for the drug. It was originally developed in 1923, trademarked under the brand name of Dilaudid in 1926, and they constructed the name Dilaudid to kind of mirror the drug of choice, which at the time was laudanum. So you can kind of see the names are close. They have that laud in them, so people can identify the two drugs as both being opioids. The first reported FDA-approved Dilaudid for the US market was in 1984. So we're talking about nearly 40 years, 40 plus years of use in the US that is, approved by the Food and Drug Administration. All right, so this is a little bit of a deeper dive into the pharmacology of the drug, why it works inside of the body, the mechanism of action. Essentially, opioids and opioid agonists, they find your opioid receptors on your cells and they bind to those. And your receptors are the mu1, mu2, kappa, and delta. Those are your opioid receptors on your cells. And most opioid drugs, especially those that are formulated or synthetic drugs, specifically target the mu1 receptor. Some drugs, especially the non-synthetics like morphine, have an affinity to mu1 and also a fairly good affinity to mu2, which you can see here produces constipation, respiratory depression, and that's why the pharmaceutical industry has come around and started to derive these synthetic opioids, okay, that don't target the mu2 receptor quite as much, okay? We want to try to get away from those adverse effects of these opioids, the constipation, respiratory depression, nausea, vomiting, those types of things, and instead focus on the analgesia, euphoria, and sedation component that are really isolated to your mu1 receptor. All right, so let's discuss the pharmacology a little bit, talk about the metabolism. Much like acetaminophen, hydromorphone is metabolized in the liver. This is a very common pathway for the vast majority of our pharmaceuticals. And it goes through a process of conjugation, of combining itself with glucuronic acid, which moves it through the kidneys and then it's able to be excreted in your urine. The effect of hydromorphone is about 5 to 10 folds greater than morphine because it's a semi-synthetic. It's been tweaked in the lab as such to be more more potent. Okay, and this is similar to fentanyl. Fentanyl is about 100 times as potent as morphine, and then you've even got carfentanil, which is about 1,000 times more potent than morphine. So the more we engineer these synthetic opioids, the stronger their potential can be. And in this case, Dilaudid's been around a very long time, and so its potency is not nearly as great as the newer formulation of opioid drugs like fentanyl or carfentanil. All right, so I know you're all really, really interested in understanding how opioid receptors actually block pain. This is a really interesting part of the conversation, I think. And when you talk about how a drug works inside of the body specifically, we touched on previously that these opioid receptors are on our neurons, okay? And when a drug like Dilaudid binds to these receptors on our neurons, it essentially reduces the activity between the two, okay? It blocks the signal from the presynaptic neuron going to the postsynaptic neuron. So the ability for that pain sensation that's originating in a specific part of your body transmitted through your nervous system up to your central nervous system and eventually into your brain is blocked. Okay, that's what these opioid drugs are doing. They're combining into those opioid receptors and not allowing as much neurotransmission to go up to your brain. So the pain problem is still there. It's just our brain can't sense it. That's how these opioids work. All right, so this is probably the most important question that people are going to ask. Morphine is going away in favor of Dilaudid. Okay, and why have we chosen to do that? So there's three main reasons that I can find. I'm sure there's plenty of other reasons as well, but really what we're talking about is the analgesic effect of the drug. Okay, how good is it at doing? How good is it at doing its job that it's supposed to do? So hydromorphone is, you know, via the research, slightly better than morphine because it can reach its peak plasma concentration a little bit faster, okay, resulting in quicker pain relief, okay. It's not as fast as fentanyl per se. So in the initial phases of pain control, when you're looking to pull an opioid out, fentanyl is probably a better choice because it can get into your system faster, it's more potent. But if we're talking about duration of action, okay, now this is where Dilaudid or hydromorphone kind of comes into its own because it lasts a really long time in comparison to fentanyl. Its its onset and duration is similar to morphine, but we have less adverse effects and it comes on a little bit quicker than morphine. So that's why we're kind of transitioning to this drug. That's the main reason. The secondary reasons, okay, chronic kidney disease is a big problem in our populations. Morphine and codeine are not recommended in these patients because they can accumulate in the person's body. They can't excrete them well because these drugs create a toxic metabolite as part of their breakdown process, and that can harm the kidneys further. Okay, hydromorphone is generally considered safer than morphine for these patients. The third reaction here that we're talking about is an autoimmune response or an immune response. And these responses are the result of generally histamine release or mast cell release. Okay. Mast cell release are more aimed towards a true anaphylactic or allergic reaction versus histamine release. Sometimes we just get those side effect profiles that we're looking for. So a little bit of hypotension, maybe a little bit of nausea, vomiting, maybe a little bit of itchiness, rash, things like that. Not a full-blown anaphylactic reaction, but a generalized adverse reaction. Okay, so with hydromorphone and Dilaudid, the incidence of adverse reactions are slightly less than morphine. It's not a great deal, but any incremental gain that we can get in this department, I think we would argue is good for our patients. All right, so let's discuss the contraindications. Pretty brief here. True opioid hypersensitivity, it's very rare, okay? And in most cases, when you drill down into the data, it was actually just an adverse reaction. The adverse reactions to opioids really do mimic anaphylaxis in many ways. A little bit of hypotension, itchiness, rash, nausea, vomiting. These are all things that can be looked at into, a sign and symptom of having an anaphylactic reaction. So many of the anaphylactic reactions are actually just adverse reactions. They're not true anaphylaxis. The one that's more pertinent for us is the concurrent use of monoamine oxidase inhibitors, or MAOIs. Okay, and this is something that's really important for both people working in the ambulance to have an understanding of. Okay, because your EMTs might be gathering some of this background information for you while you're treating the patient as a paramedic, or vice versa. Okay, the paramedic might be gathering information while the EMT is making some treatment decisions. Okay, so if you look at somebody's medication list or you talk to them about the drugs that they're taking, some of the common MAOIs out there, the ones that I've seen most often are Eldepril, but I have also seen Parnate and Marplan and Nardil. Okay, these are common drugs out in our communities because they are drugs that are widely used for depression, and also now more recently, probably in the last decade or so, that have been recognized for their ability to help with Parkinson's-like symptoms. Okay, so when you combine opioids with serotonergic medications like MAOIs, you can develop something called a serotonin toxicity. Okay, and that's where essentially the body cannot regulate its serotonin, and you end up with some really nasty secondary complications, including things like coma and death. Okay, so what we want to make sure is we're looking at our patients' medication lists. If they have any MAOIs on there, we talk to them about when they had last taken them. Many people don't take their antidepressant medications, okay? And so opioids still might be indicated in these patients, but we just need to be suspicious. Right, so let's talk about the onset and the duration of the drug. Intravenous onset is obviously significantly quicker than intramuscular for our adult patients, so that's the preferred route. But if you don't have an IV or an IO, you can definitely achieve some, good analgesia with an intramuscular administration of the drug. The duration of action here, 3 to 4 hours. Okay. So that is really great in our situations where we have a longer span of care for our patients, interfacility transfers, or maybe you're a long way out from hospital and you're thinking, right, I have given them 100 of fentanyl. Now I don't want to be just continuously bolusing fentanyl over this hour-long transfer. Maybe I'll just give some Dilaudid. Okay. That's definitely an option, and I think it's probably a good use of your opioid analgesics if you decide to go that way. Right, adverse effects. I think we're all pretty aware that opioids have quite a few adverse effects. Most common that you're probably going to see: nausea, vomiting, respiratory depression, confusion, maybe a little bit of dizziness, drowsiness, headache, things like that. Okay. Most of the adverse effects that opioids are going to cause are pretty mild and don't have any significantly lasting effects. Okay. So they shouldn't really interrupt us from trying to manage somebody's pain. Just because you get a little bit nauseous doesn't mean that your 9 or 8 out of 10 pain doesn't need to be controlled. Okay. So things that you can do to combat this, obviously, in your patients with respiratory depression, put them on a little bit of nasal cannula oxygen. Your patients with a little bit of nausea, you could give them some ondansetron. Okay, so there are ways around our adverse effects associated with opioids. I think we're all pretty aware of these, but it's good to just touch on them every now and then. All right, a quick summary of what we discussed. Hydromorphone, brand name Dilaudid, hopefully rolling out sometime in August. That's contingent on us getting the supply through pharmacy. people training on the drug, it being distributed to station 1, getting it in the safe, getting it onto vector check. Okay, so there's a lot of things that have to happen in the background that we have to plan out. So I would not be surprised if that kind of gets delayed a little bit, August to September, right? September to October. There's always the possibility of that. Completing the education is very important. Please tell the people that you're working with about the education and encourage them to partake in these EMS1 training sessions, because it's very important for us for new drugs, new equipment, new procedures, or changes in protocols that are significant, okay, for us to understand the what, where, when, why, and how of all of these things, okay? If you have questions surrounding the change in protocol, please contact myself. If you see Dr. Burtis in the ED, you can talk to him about it as well. This drug was specifically brought to our attention by people who've worked in other services and had a really great experience with them. So this is something that's homegrown from the paramedic cohort here at Magic Valley. It's something that's been requested by the frontline staff. So I'm really happy to be able to say that it's coming to fruition. I hope you all have a great start to your July. Like I said, encourage other people to get online and take these courses, okay? We'll see you all soon.